Most adults over 60 have been told what symptoms to watch for when it comes to cancer. Unexplained weight loss, persistent fatigue, a lump that does not go away. These are the cancer warning signs that appear on awareness posters and in public health campaigns, the dramatic, unmistakable signals that most people understand warrant urgent medical attention. What most people have never been told, and what a significant body of clinical research consistently shows, is one of the earliest and most reliable warning systems the body provides for gastrointestinal cancer is what their stool looks like. Not its shape, not its consistency, its color, its composition, what it contains beyond the obvious. What the presence of blood, mucus, fat, or specific discolorations reveals about the health of the organs through which digestion has passed. The color and composition of stool is, in clinical gastroenterology, a diagnostic window. It reflects the state of the gastrointestinal tract from the esophagus to the rectum, and in adults over 60. Specific deviations from the normal brown color and uniform composition of healthy stool are among the most clinically significant and most consistently underreported early warning signs for gastrointestinal malignancy. I need to state clearly and at the outset, nothing in this video is a substitute for medical evaluation. Every stool color and composition change I described today has both benign and malignant potential causes. The appropriate response to observing any of these changes is not self-diagnosis. It is a conversation with your physician. The purpose of today's video is to ensure that you have that conversation, because the research consistently shows that early detected gastrointestinal cancer has dramatically better outcomes than late detected disease. Here is the cancer epidemiology that provides the clinical context for everything we discussed today. Gastrointestinal cancers, cancers of the esophagus, stomach, small intestine, colon, rectum, pancreas, liver, and gallbladder collectively represent the most common category of cancer by anatomical system in adults over 60. The American Cancer Society identifies colorectal cancer as the second leading cause of cancer death across both sexes combined, with the vast majority of cases occurring after age 50 and the incidence curve accelerating significantly after 60. Beyond colorectal cancer, gastric cancer, stomach cancer occurs at a median age of 68, with the majority of cases diagnosed at advanced stages because its early symptoms are nonspecific and frequently dismissed. Pancreatic cancer, with its notoriously poor prognosis, has a median age at diagnosis of 70 and produces stool changes, specifically steatorrhoea and pale, floating stools, that are recognized warning signs in the clinical literature, but are almost never recognized by patients as significant. The World Gastroenterology Organization has published global guidance specifically identifying stool color changes, blood in stool, pale or greasy stools, and dark tarry stools as priority warning signs for GI malignancy in adults over 60, noting that the positive predictive value of these findings for significant GI pathology increases substantially with age. Today we are going to go through 5 specific stool color and composition findings, what they look like, what they mean biologically, which cancers they are associated with, what the evidence shows, and what you should do immediately upon observing them persistently. Before we begin, leave your age in the comments. And tell me, have you ever noticed an unusual stool color and dismissed it without mentioning it to your doctor? Your honesty is important because that pattern of dismissal is one of the most significant contributors to late-stage gastrointestinal cancer diagnosis. 5 stool colors and composition findings. Each one a specific clinical signal with a specific biological mechanism. Each one associated with specific gastrointestinal pathology that is more prevalent and more dangerous in adults over 60 than in younger populations. For each finding, I will tell you what it looks like, what biological process it reflects, which cancers it is associated with, what the clinical evidence shows, and what you should do upon observing it persistently. The key word throughout is persistently. A single unusual stool is almost never clinically significant. A pattern, a change that persists for days or weeks, that recurs, that represents a departure from your personal normal, is what demands attention. Let's go through them. Finding number 5, pale, gray, or clay-colored stools. Stools that are significantly lighter than the normal brown color, appearing pale tan, gray, putty-colored, or clay-like. This is a dramatic departure from the normal brown color of stool and is difficult to miss once you understand that it is clinically significant. The brown color of normal stool comes from stercobilin, a pigment produced when bile from the liver passes through the gastrointestinal tract and is modified by bacterial action in the colon. Normal bile production, normal bile flow from the gallbladder into the small intestine, and normal bacterial processing of bile salts are all required for stool to be its characteristic brown color. When stool is pale, gray, or clay-colored, it means that bile is not reaching the small intestine in normal quantities. This condition, called acolic stool, indicates obstruction of the bile ducts. Bile, instead of flowing into the intestine, is accumulating in the liver and gallbladder, producing the elevated bilirubin that causes jaundice, the darkening of urine, and the pale stools that are the triad of biliary obstruction. The Cancer Association. In adults over 60, the most clinically significant causes of biliary obstruction producing pale stools are pancreatic cancer, specifically cancer of the head of the pancreas, which is anatomically adjacent to the bile duct and commonly obstructs it as it grows. Pancreatic head cancer is one of the most lethal gastrointestinal cancers, with a 5-year survival rate of approximately 10%, and pale stools combined with jaundice and dark urine constitute the classic early symptom triad that, when identified and investigated promptly, represents the best opportunity for curative surgical resection. Cholangiocarcinoma, bile duct cancer, which directly obstructs the bile duct it arises in, producing biliary obstruction and pale stools as primary presenting features. Gallbladder cancer, which can compress the bile duct as it grows, producing the same acolic stool picture. Research published in JAMA Oncology found that jaundice combined with pale stools and dark urine was the presenting symptom triad in approximately 55% of pancreatic head cancer cases, and that patients who presented with this triad and underwent prompt investigation were significantly more likely to be diagnosed at a surgically resectable stage than those who delayed investigation. A systematic review in gut found that pale acolic stools in adults over 60 had a positive predictive value for biliary tract malignancy of approximately 15 to 20%, making it one of the highest yield cancer warning signs in GI medicine. What to do? Pale, gray, or clay-colored stools, particularly when accompanied by yellowing of the skin or whites of the eyes, dark amber urine, or upper abdominal discomfort, constitute a medical urgency. Contact your physician today, not next week. This symptom combination requires prompt imaging of the biliary system and pancreas, typically beginning with abdominal ultrasound and proceeding to CT or MRI as indicated. Finding number 4, dark red or maroon-colored stools. Stools that are dark red, maroon, or burgundy in color, not bright red blood on the surface of otherwise normal stool, but stools that are themselves darkened by blood mixed throughout. Sometimes the entire stool is darkened by a reddish-brown or maroon hue. The toilet water may appear red or pink. Dark red or maroon stool, called hematochezia when blood is visible in stool, indicates bleeding from the mid to lower gastrointestinal tract, typically the ascending or transverse colon. Blood from this location has had sufficient transit time to partially darken, but not enough to fully convert to the black haemadin of upper GI bleeding. The result is the dark red or maroon discoloration that is intermediate between bright red lower GI blood and black upper GI blood. The significance of this specific color is its anatomical implication. Bleeding that is dark red or maroon is most commonly arising from the right colon, the ascending colon, and cecum, where colorectal cancers are particularly insidious because they bleed less visibly than left-sided tumors and produce anemia and fatigue rather than the bright rectal bleeding that typically prompts earlier investigation. Right-sided colorectal cancer, cancer of the cecum, ascending colon, and transverse colon accounts for approximately 30% of colorectal cancer cases and is associated with consistently later diagnosis than left-sided disease because it bleeds in a less visible fashion and does not typically alter stool caliber in ways that produce the narrow ribbon-like stools associated with left-sided disease. Dark red or maroon stool in adults over 60, in the absence of a clear benign cause such as diverticular bleeding, warrants urgent colonoscopy to exclude right-sided colorectal malignancy. Research published in Annals of Internal Medicine found that right-sided colorectal cancers were diagnosed at a significantly more advanced stage than left-sided tumors, attributing the difference in part to the less visible nature of right-sided colonic bleeding, which was more likely to present as maroon discoloration or occult blood rather than the bright rectal bleeding that more promptly alerts patients and physicians. A study in clinical gastroenterology and hepatology found that adults over 60 presenting with maroon stools without hemodynamic instability who underwent early colonoscopy had significantly higher rates of malignancy detection compared to those managed conservatively. What to do? Dark red or maroon-colored stools in an adult over 60, persisting for more than 1 or 2 bowel movements without a clear benign explanation, warrant same-day or next-day physician contact. This symptom requires urgent evaluation to rule out significant GI bleeding from either benign or malignant causes. Finding number 3, Greasy, OLY, or floating stools, steatorrhoea, stools that are greasy, shiny, or oily in appearance, sometimes leaving an oil slick in the toilet bowl. Stools that float rather than sinking, particularly if they are pale and greasy simultaneously. Stools that are difficult to flush and leave residue on the toilet bowl. These stools frequently have an unusually strong foul odor. This is called steatorrhoea, fat in the stool. Normal fat digestion requires 2 things: pancreatic lipase, the enzyme produced by the pancreas that breaks down dietary fat, and bile salts, produced by the liver and delivered through the bile duct, which emulsify fat and prepare it for enzymatic digestion. When either of these is absent or insufficient, dietary fat passes through the gastrointestinal tract undigested and appears in stool as the greasy, floating, pale, malodorous material that characterizes steatorrhoea. The 2 organs most directly responsible for fat digestion, the pancreas and the biliary system, are also the sites of some of the most lethal gastrointestinal cancers in adults over 60. When a pancreatic tumor destroys enough of the exocrine pancreatic tissue to impair lipase production, or when biliary obstruction prevents bile salt delivery to the small intestine, fat malabsorption and steatorrhoea result. The Cancer Association, steatorrhoea in adults over 60 is one of the most specific early warning signs for exocrine pancreatic cancer, the pancreatic cancer of the acinar and ductal cells that constitutes the vast majority of pancreatic malignancies. It is also associated with biliary tract cancers that obstruct bile flow, and with ampullary cancer, cancer of the ampulla of Vatta, the junction where the bile duct and pancreatic duct enter the small intestine. Pancreatic cancer is the cancer for which steatorrhoea is most clinically significant because it is a cancer for which early detection genuinely matters. The 5-year survival rate for localized pancreatic cancer confined to the pancreas is approximately 44%. For distant stage disease, it is approximately 3%. Steatorrhoea can be an early sign of pancreatic cancer, sometimes preceding the diagnosis by months, and recognizing it promptly is one of the few mechanisms by which pancreatic cancer may be caught at a stage where curative treatment is possible. Research published in Pancreas found that steatorrhoea was a presenting symptom in approximately 20 to 25% of pancreatic cancer cases, and that patients who reported this symptom to their physician promptly were significantly more likely to have their cancer diagnosed at an earlier, potentially resectable stage. A systematic review in the British Journal of Cancer found that new-onset steatorrhoea in adults over 60 had a positive predictive value for pancreatic or biliary malignancy of approximately 8 to 12%, substantially higher than most individual cancer symptoms. Greasy, oily, floating, pale stools, particularly if they are accompanied by unexplained weight loss, upper abdominal discomfort, or jaundice, require urgent medical evaluation. Contact your physician and describe the stool appearance specifically. This symptom constellation requires pancreatic and biliary imaging, abdominal ultrasound, CT scan, or MRI to evaluate for pancreatic or biliary pathology. Finding number 4, black, tarry stools, melaena. Stools that are black, not dark brown or very dark brown, but genuinely black, with a sticky, tar-like consistency. They frequently have an unusually foul, distinctive odor that is different from normal stool odor. They may appear shiny or adhesive. This is called melaena. Melaena is produced when blood from the upper gastrointestinal tract, the esophagus, stomach, or duodenum passes through the length of the small intestine and colon. During this transit, hemoglobin in the blood is converted by bacterial and digestive enzymes to haemoglobin, a black iron compound that gives melaena its characteristic color and consistency. The black, tarry appearance indicates that at least 50 to 100 milliliters of blood have entered the upper GI tract, a significant hemorrhage from whatever the bleeding source is. In adults over 60, melaena most commonly indicates one of the following: gastric cancer, stomach cancer, which bleeds into the stomach lumen and produces melaena as digested blood passes through the intestinal tract. Gastric cancer has a median age at diagnosis of 68 and a 5-year survival rate that falls dramatically from approximately 70% for localized disease to under 6% for distant disease. Melaena is a presenting symptom in a significant proportion of gastric cancer cases, and its prompt investigation through upper GI endoscopy provides the opportunity for early-stage diagnosis. Esophageal cancer, which bleeds from the esophageal tumor into the stomach and then into the intestinal tract. Esophageal cancer is strongly associated with older age and certain risk factors: chronic reflux, Barrett's esophagus, heavy alcohol use, smoking, and melaena may be one of its early presenting features. Gastric lymphoma and gastrointestinal stromal tumors, rarer but significant malignancies that can bleed into the GI tract and present with melaena. Research published in Gastrointestinal Endoscopy found that melaena in adults over 65 had a significantly higher probability of identifying an upper GI malignancy on endoscopy compared to younger adults presenting with the same symptom, reflecting the higher underlying malignancy prevalence in this age group. A study in the American Journal of Gastroenterology found that adults over 60 with melaena who underwent urgent upper GI endoscopy had malignant pathology identified in approximately 10 to 15% of cases, making it one of the most malignancy-enriched presentations in emergency GI medicine in older adults. Black, tarry stools in an adult over 60 are a medical emergency requiring same-day evaluation. Do not wait for a routine appointment. Contact your physician immediately or go to the emergency department if the stool is very black and tarry, if you feel faint or dizzy, or if you have vomited blood. Upper GI endoscopy is required urgently to identify and manage the bleeding source. Finding number 1, stools positive for occult blood, the invisible warning. And here is the finding that earns the top position on today's list. Not because it is the most dramatic, it is invisible. Not because it produces the most obvious symptoms, it produces none at all. But because it is the most common early warning sign of colorectal cancer, the one most consistently identified at the stage when treatment is most effective, and the one most consistently missed because most people do not know it is there until they are tested for it. Fecal occult blood, blood and stool that is invisible to the naked eye. Present in quantities too small to produce any visible discoloration, too small to produce any pain or awareness, but detectable through a simple, non-invasive stool test, the fecal occult blood test or its more sensitive successor. The fecal immunochemical test that can be performed at home with a kit available through most healthcare providers or pharmacies. Colorectal polyps and early-stage colorectal cancers bleed into the bowel lumen in small quantities, too little to produce visible discoloration, but enough to be chemically detected. This low-level, invisible bleeding, called occult blood, reflects the fragility of the tumor's blood supply and the surface ulceration that occurs as even early-stage polyps and cancers develop. Because the bleeding is intermittent and small in volume, stool may test positive on some days and negative on others, which is why the clinical recommendation is for regular testing rather than a single negative result being treated as definitive reassurance. Why occult blood testing is the most powerful early detection tool available. The fecal immunochemical test, FIT, specifically detects human hemoglobin in stool, eliminating the dietary interference that affected older guaiac-based tests. Annual FIT testing in adults over 50 has been shown in multiple large-scale randomized trials to reduce colorectal cancer mortality by 15 to 33%. Through the detection and investigation of occult blood that leads to colonoscopy, polyp removal, and early-stage cancer diagnosis. The landmark Minnesota colon cancer control study, a randomized controlled trial involving over 46,000 adults, found that annual fecal occult blood testing reduced colorectal cancer mortality by 33% over a 13-year follow-up period. This remains one of the most significant cancer mortality reductions ever demonstrated for a screening intervention. Subsequent studies of the fecal immunochemical test, the modern successor, have produced consistent findings. Research published in the New England Journal of Medicine found that FIT-based colorectal cancer screening programs detected colorectal cancer at an earlier stage compared to symptom-based diagnosis alone, with the stage shift toward localized disease representing the mechanism of mortality reduction. The United States Preventive Services Task Force recommends annual FIT testing or colonoscopy every 10 years for all adults aged 45 to 75, with continued testing beyond 75 based on individual risk assessment. The most important message of today's entire video: if you are over 60 and you have not had a FIT test or colonoscopy in the last year and 10 years, respectively, you may currently have occult blood in your stool that would prompt colonoscopic investigation that could detect and remove a polyp or diagnose a cancer at its most treatable stage. The test is simple, non-invasive, free in most healthcare systems, and takes less than 5 minutes to complete. The failure to perform it is not a minor oversight in the context of colorectal cancer's steep stage-based mortality gradient. It may be among the most consequential health decisions an adult over 60 makes. Contact your physician today and ask for a fecal immunochemical test if you are not already undergoing regular colorectal cancer screening. If a positive FIT result is identified, meaning occult blood is detected, a colonoscopy is required. A positive FIT result is not a cancer diagnosis. It is a reason for further investigation. And that investigation, colonoscopy, is one of the most powerful cancer prevention and early detection tools available because it both identifies and removes the polyps that are colorectal cancer's precursor lesions. The 5 actions to take. Action 1. Know which stool color changes require same-day evaluation. Black tarry stools and pale gray stools combined with jaundice are medical urgencies. They require same-day or emergency evaluation, not a routine appointment. Every adult over 60 should know these 2 color changes and respond to them immediately. Action 2. Get a fit test today if possible. If you have not had a fit test in the last year and have not had a colonoscopy in the last 10 years, request a fit test today. It is the single highest impact cancer screening action available for adults over 60 that requires no preparation and no procedure. Action 3. Never attribute rectal bleeding to hemorrhoids without investigation. Hemorrhoids bleed. Colorectal cancers bleed. Both can be present simultaneously. In adults over 60, any rectal bleeding, visible or reported, warrants colonoscopic investigation before being attributed to a benign cause. Action 4. Report greasy, floating, or pale stools to your physician promptly. Steatorrhoea is a symptom that most patients consider embarrassing and most physicians never ask about. It is also one of the most specific early warning signs for pancreatic cancer, a disease where early detection genuinely changes survival. Report it. Action 5. Understand that normal appearing stool does not exclude cancer. Early colorectal cancer frequently produces no visible stool changes whatsoever. Screening, fit testing, or colonoscopy detects disease that produces no symptoms. The absence of unusual stool color or appearance is not a reason to forego screening. It is a reason to continue it. The gastrointestinal tract produces information every single day. It communicates through the color, the composition, and the characteristics of what it produces, and most of that communication passes unread because the culture around bowel health is one of avoidance and embarrassment rather than attention and action. The clinical research is unambiguous. Gastrointestinal cancers are among the most treatable malignancies when detected early and among the most lethal when detected late. The difference between those 2 outcomes is frequently determined not by tumor biology, but by how promptly a warning sign was recognized and investigated. You now know 5 color and composition findings that warrant medical investigation. You know what pale stools mean for the pancreas. You know what melaena means for the upper GI tract. You know what steatorrhoea is and why it matters. You know that the most important stool finding of all is invisible and detectable only through a simple test that most adults over 60 have never had. Use this knowledge. Today, not next week. Leave a comment telling me your age and whether you have had a fit test or colonoscopy in the recommended time frame. Your answer and the responses of this community will tell a story about how well gastrointestinal cancer screening is reaching the people who need it most. If this video gave you something worth knowing, please hit like and share it with someone over 60 who has been dismissing unusual stool changes as nothing to worry about. That dismissal, in the context of GI cancer, costs lives. Subscribe for weekly content on cancer prevention, early detection, and the clinical information adults over 60 deserve to have clearly communicated. Your gastrointestinal tract is speaking. Know its language.